Thank you for joining us this evening for our presentation on the COVID-19 vaccines for children. My name is Nicole Gerber, and I'm one of the doctors in the Pediatric Emergency Department at Cornell. And I'm excited to be joined this evening by my colleagues, Dr. Deborah Levine and Dr. Sherry Platt, also from the Pediatric Emergency Department, as well as Dr. Karen Acker, a pediatric infectious disease specialist, and Dr. Patrick Flynn, one of our pediatric cardiologists. We're also very excited to be joined by the chair of our Department of Pediatrics, Dr. Sally Permar, who's also an infectious disease specialist. And I'm going to pass things off to her for a moment for a brief introduction.
Thank you, Dr. Gerber, and thank you to this team for putting this really important session together for information from your pediatricians to families, to parents who are making this decision about their child's vaccine. So I just want to welcome everyone. I am thrilled to be joining here as the department chair of pediatrics at Weill Cornell Medicine and the pediatrician in chief at New York Presbyterian Kamansky Children's Hospital. I am also here as a pediatric infectious disease physician, as a vaccine researcher, and as a parent of a child that falls in the 5 to 11 year range. And so I know where all of you are coming from on wanting to have the most information to make the best decision for your child. I'm also thrilled that we're at this moment in the pandemic, that we have come to a time when the remarkable innovation of the COVID-19 mRNA vaccines are now available to our children in the school age range from 5 all the way up to adulthood. It has been one of the most remarkable pursuits in all of vaccine history. One of the most remarkably safe and effective vaccines that we have available for COVID. And it's something that has really changed the trajectory for us in the pandemic, because we know that we have the best tool to provide protection against severe disease from COVID-19 and remarkable protection even against acquisition of the virus and transmission of the virus. So I'm also thrilled that this is a time in which we have watched vaccinology play out for children, where the vaccines were tested specifically in this age group and designed and dosed in a way that was specific to this age group. And that's really never happened in such a precise way before. And to see precision vaccinology going into place for our children is something that's a new era really in vaccinology. And I want to recognize that there are a lot of questions that we're getting, not only from our parents and our families, but even from other doctors, from other parts of the medical field, who want to know, what do pediatricians think about this vaccine and supporting it for our children? Do they really need it? Is it worth any potential side effects? And that's the questions that you're going to get answered today. And so thank you very much again to this remarkable team who's come together to give you all of that information. I will hand it back over to you, Dr. Gerber.
Thank you so much, Dr. Permar. So we're going to get started. So the Pfizer vaccine has been approved for the 12 to 16-year-old age group for a little while now, but approval for the 5 to 11-year age group, as we all know, just came out very recently. So we know that there are a new group of parents that are just starting to make this decision of whether or not to vaccinate their child. So what we're going to do is start by taking you through the results of the vaccine studies. And then, as Dr. Permar mentioned, we're going to go through some of the common concerns that we're hearing about the vaccines. And we will have time at the end for questions, and we really do welcome your questions. The way to submit questions is through the question and answer. We will not be taking live questions. And then just to keep in mind, we are not able to give specific medical advice, so medical advice that's particular to your child or family, but we are happy to give kind of general answers to the questions. And as Dr. Permar mentioned, we are actually all parents, so we have been making these decisions for our families too. And so we hope that we can address all of your questions and help to allay some of the fears. On the next slide, we're going to start by talking about the data from the Pfizer trials. And we're going to start with the 12 to 15-year-olds and then the even more recent data that just came out on the 5 to 11-year-olds. But before we start really getting into the details about the results, I want to mention a few of the concepts that come up in the studies so that we can all understand the way that they analyze the results. So the first concept is immunogenicity or antibody response. And this was the main outcome of the studies. They looked to see if the level of antibody production in the younger age groups, what the antibody production was in the younger age groups after each dose of the vaccine. And then the second concept is immunobridging. And this helps to explain why we didn't need as many participants in the studies for the pediatric studies compared to the initial adult trials. We already know that the vaccine works to prevent severe disease from these adult studies. And so what we did was we compared the 16 to 25-year-old age group to these newer age groups, the 5 to 11-year-olds and the 12 to 15-year-olds. And we looked to see if the amount of antibody production was the same between those two groups, because we know that the antibodies produced in the 16 to 25-year-old age group were protective against severe disease and disease acquisition itself. And then the last concept is efficacy, which is how well the vaccine works in the trials to prevent disease. And just to say that's compared to effectiveness, which is how well the vaccine works to prevent infection in the real world. So starting with the trial in the 12 to 15-year-old age group, so the study enrolled over 2,000 adolescents, half of whom received the vaccine. And because it is a smaller group, since we didn't really need to show efficacy because we already know that the vaccines work if you get a strong antibody production, they looked at the antibody responses. They weren't sure if they were going to show efficacy. So we don't know entirely what antibody level is protective against disease, but we do know that, as we mentioned previously, the 16 to 25-year-old age group had a robust antibody response and it prevented disease. And so what we did was compare the antibody development in the 12 to 15-year-olds to that in the 16 to 25-year-olds. And they did find a similar antibody response, and that these antibodies work to stop SARS-CoV-2, the virus that causes COVID-19. And then ultimately, they were actually even able to show efficacy. So 18 participants in the placebo group did develop COVID-19, while none of them in the vaccine group developed COVID-19 after receiving the second dose, which was great. And at this point, over 13 million children in this age group have been vaccinated. And then on the next slide, I know overall we worry, like, how are our kids going to feel after they get the vaccine in the next couple of days? And kids in the 12 to 15-year-old age group did really well. The figure on the screen shows the common symptoms that children experienced after receiving the vaccine compared to the kids who received the placebo. And what you can see on the slide is that there were a lot of children who had a sore arm. There were some children who had fatigue and headache. Although if you look, even some of the kids who got the placebo doses had these symptoms as well. Not many of the kids developed fever, and the symptoms were generally all short-lived. So moving on to the trials for the children 5 to 11 years old. So for the younger age group, the first step was actually deciding what dose to use. Children tend to have more reactogenicity to vaccines, meaning that they develop more of a robust immune response to vaccines. So the first step was important to decide what would be the best dose for kids, and the best dose being the smallest dose to get a good response. So they had tested out a couple of different doses, and since they found a similar antibody response with all of the doses that they tried, they went with the lowest effective dose, which is a 10 microgram dose, compared to the 30 microgram dose in the adult vaccines. And then for the second part, the phase 2-3 trial, so I know a lot of people may have heard about the study results taking longer to come out because they were enrolling more children. So they actually had two cohorts of children enrolled. The first cohort had about 2,000 participants, and then they had a second group of an additional 2,000 children for additional side effect and safety data. Similar for the 12 to 15-year-olds, they looked at the antibody response, again comparing it to the 16 to 25-year-olds, and they did again find a similarly strong antibody development, which was comparative to the 16 to 25-year-olds. And again, they actually were able to show efficacy as well. Ultimately, there were 16 children in the placebo group who developed COVID-19 compared to only 3 in the vaccine group. And the children in the vaccine group had very, very mild illness. None of them actually even had fever. And then again, how did the kids feel after getting vaccination? So similar to what we've seen from all of the vaccine studies, the most common reactions were pain at the injection site. And this graph, again, looks at the symptoms in the children who received the vaccine compared to those who received the placebo. And actually, compared to the older age groups, they were even less likely to experience things like fatigue, headache, and fever. So they were even feeling a little bit better after the doses of the vaccine compared to some of the older children. So that's an overview of the data from the trials. And what we learned from the trials is that the vaccines work and are actually generally really well tolerated by children. So for the next part, we're going to switch gears a little bit and move into the Mythbusters section. And this session is really set up to discuss some of the concerns that we're hearing from families as they make this decision about whether or not to vaccinate their children. And so Dr. Karen Acker from Pediatric Infectious Disease is going to start us off with our first myth.
Thank you, Dr. Gerber. So I'll just get started. We have many myths that we've been hearing about, and I'm going to do my best to bust them. So the first myth is that children don't get COVID-19. So we now know this is not true. There have been more than 6.5 million cases of pediatric COVID-19 across the United States, about almost 2 million in the 5 to 11 age group. And early in the pandemic, it did seem that maybe children weren't getting infected as often. But this was in the setting of lockdowns, strict distancing, and decreased testing of children. And now we know that children are as likely to get infected with COVID-19, but are less susceptible to severe disease. And as you can see in this graph, the light blue represents adult cases and the dark blue represents pediatric cases. And as the pandemic has ensued, so this is showing throughout since the beginning of the pandemic and with all the waves, that the overall number of children has increased. And the proportion of children occupying those positive cases has increased. And now, most recently, children occupy about 24% of cases of COVID-19. The next myth, so we know that children can get COVID-19, but many think that children don't get sick from COVID-19. And we are fortunate that children are less susceptible to severe disease, but they can still get very sick. And we know they're not spared by severe disease. So overall, there have been close to 600 deaths caused by COVID-19, close to 150 in the 5 to 11 age group, and thousands have been hospitalized. Overall, having an underlying condition, like a chronic medical condition, does put children at higher risk for severe disease, but still 1/3 of children that are hospitalized have no underlying conditions. So in comparison though, during a really bad influenza season, less than 200 children died. So while children are at much lower risk than adults are, they're still not spared and they still need to be protected. In addition, there's another complication that we've seen of COVID-19 in children that's pretty specific to children. It's known as a multi-system inflammatory syndrome in children, or MIS-C, or MIS. And we see that this can occur several weeks after COVID-19 infections and often results in hospitalization. So it's not a benign condition. Thus far, there have been over 5,000 cases of MIS-C reported in the United States with around 50 deaths. And you can see from the graph on the screen that the age group we're talking about primarily today, the 5 to 11 age group, occupies the largest age group that we've seen with MIS-C. So this really further emphasizes the importance of getting this group vaccinated and protected from COVID-19 infection. And then lastly, we still don't have a great understanding of the post-acute sequelae of COVID-19, or what we refer to as long COVID. This is something that we really saw initially in adults and really characterized by multiple symptoms, whether it's shortness of breath, fatigue, difficulty concentrating with brain fog. And overall, we don't know how many children are affected by this, but we have seen reports And we know that some people will continue to have symptoms that interfere with their daily activities for weeks to months. And even in adults, some are still suffering for over a year from their initial infection. So in all, we know that children have not been spared from COVID-19, either due to the infections or their potential complications. So the next myth is that, I hear a lot, my child doesn't need the COVID-19 vaccine because natural immunity is somehow better. So let me first just go through what we mean by natural immunity. So that really refers to the immunity we generate after a natural infection. So we had an infection by the virus and we mounted an immune response. And the thing about natural immunity is that it's very variable from person to person. So some are immune for months, some for shorter, but we don't know who is more immune than others. And this is especially true as we are exposed to new variants of the SARS-CoV-2 virus. So I can't predict what your child's personal immune response is going to be or how long it's going to last. But what we do know is that the vaccine does mount a very good response, that it's quite consistent. And so I emphasize to everyone that every child should get the COVID-19 vaccine, even if they had a prior infection. And this just brings me to kind of give a quick overview of how the vaccine works. And I know that we've seen concerns that, does the vaccine stay in our body forever? Is it going to cause effects going forward? So the vaccine, when it doesn't live in your body forever and prevent COVID. So really what it is, it contains a particular component called mRNA or messenger RNA that we already have in our bodies. We make mRNA all the time to help translate our genes into a protein so that our body can function. So what the vaccine does is it gives you those instructions so that your body can basically your body can make a protein that is a part of the COVID-19 virus, but just a protein from it. And then your body sees it and can mount an immune response. So once your body mounts that response, it makes antibodies, makes T cells, B cells that are specific for that protein. And then when your body then encounters COVID-19 or the virus that causes COVID-19 in real life, it already knows how to respond and it can prevent you from getting symptoms or infection. The mRNA that's given to you doesn't last in your body for very long, really no longer than 72 hours. And then it's really what you have left are your natural immune response to that vaccine. So the next myth next concern is that there are long-term adverse effects of the vaccine. Of course, this is a concern I've heard about a lot. But really, overall, when it comes to vaccines, long-term side effects are extremely uncommon, and particularly if we don't detect any effect in the first 2 months after vaccine. So really that first 6 week to 2 month period after getting a vaccine is when we are more likely to see a side effect. But after that, it's very, very rare. And really no vaccine has been associated with a long-term effect that we didn't detect in the first 2 months. We've not seen other age groups develop long-term side effects. And I think it overall is very unlikely we will discover long-term side effects in younger children as well. We do know, however, that children can develop long-term side effects from the actual infection, including MIS-C, as I just discussed, and long COVID. And I just want to say that this is really one of the most highly scrutinized vaccines in our history. And all side effects, both short and long term, are being monitored very closely. Another myth that we've seen is that the studies in children were too small. And so I think Dr. Gerber covered this, but in explaining that while they were smaller than the studies for adults, they were really enrolled more to study safety and dosing in the younger population. The reason that we were able to be smaller is that we didn't need to focus on the proof that the vaccine works or the efficacy, and then the way that the initial studies needed to do, and hence required much larger numbers. We now have excellent data from millions of people who have been vaccinated across the world that the vaccines reduce hospitalizations and death due to COVID-19. And really the studies in children needed to determine the safety and the dosing. And we certainly had enough numbers to do that. Because adverse effects such as myocarditis are so rare, the studies would have needed to be exponentially larger to catch any of those effects. So that brings us into the next set of myths that we'll go through about some of the side effects that we see in the more immediate post-vaccine timeframe. And to address these concerns about myocarditis, I'm going to introduce Dr. Patrick Flynn, who is one of our pediatric cardiologists at Weill Cornell.
Thank you, Dr. Acker. I'm really happy to be here to address the concerns about COVID vaccine-associated myocarditis. It's a condition that we have seen, and quite frankly, it sounds much worse than it is when you hear about it in the media or when you just hear about it as a parent. By way of background, myocarditis just means inflammation of the heart muscle, and it has a lot of different causes, but we usually see it after common virus infections like Coxsackie virus in the summer or adenovirus in the winter. The severity can range from very mild disease to very severe or even life-threatening disease for all forms of myocarditis. Worldwide, there are about 2 million cases of myocarditis a year. This is probably an underestimation because the true incidence may be underestimated because minor cases will go unnoticed. In the United States, there's about 10 or 20 cases per 100,000 people a year, although the frequency is about 1/10 of that in children below puberty, so in the age group of the patients that we're starting to vaccinate now. And how does a person know that they have it? In the post-vaccine cases, it's usually about 2 to 3 days after the second dose, while the other side effects are occurring, when a patient with myocarditis will feel marked chest pain out of proportion to the rest of the discomfort that they're having. So if a person is just having fever and body aches, and one of the parts of the body that's achy is the chest, that's not myocarditis. The people with myocarditis know that they have it. With that as background, although it is understandably getting a lot of media attention, vaccine-related myocarditis is in fact very rare. That's why it wasn't found in the original vaccine trials. The most complete data comes from Israel. Out of the first 250,000 fully vaccinated children aged 12 to 15 years old, there were 12 cases of post-vaccine myocarditis. So that's about 1 in 20,000. That was lower than in the 16 to 19-year age group and lower than in young adults. And as of now, there are not yet any reported cases of post-vaccine myocarditis in children under 12 in the vaccine trials. So as mirrors myocarditis in the population from all causes, it seems as though the younger age groups will be expected to have less cases of myocarditis in the coming group. So just to put things back in perspective, myocarditis is very, very rarely seen with a vaccine, but it is seen with COVID-19 infection, and particularly with the multisystem inflammatory syndrome in children, or MIS-C, which Dr. Acker talked about before. From a cardiologist perspective, MIS-C should be viewed as an extreme and very serious form of myocarditis. And I would also add, we've not yet seen a case of MIS-C in a fully vaccinated patient. So in conclusion, you are unequivocally more likely to develop heart damage from COVID-19 infection than you are from the vaccine. And this goes for adults, and it will go for children as well. Now, the next myth is that that myocarditis has been portrayed in the media, understandably, as if it's to make it seem very dangerous. But while myocarditis from other causes, as we said before, can be a serious life-threatening illness, the cases that have occurred after the vaccine have uniformly been very mild. It doesn't compare in any way to the devastating cardiac complications that we've seen in MIS-C. Symptoms generally respond exquisitely to ibuprofen, which has generally been the only treatment necessary. We've actually had cases that have resolved after 1 dose of ibuprofen, or even one case that resolved before the ibuprofen was actually given. For the most part, hospitalizations have been very short, a day or two. Back in the summer, when it looked like we'd be seeing these cases very regularly, we were considering not even admitting some of these patients, which is not something that we've ever considered for myocarditis in the past from other causes. There have not been any confirmed deaths or serious complications yet from post-vaccine myocarditis in young people. So in summary, personally, and I'm sure I know I speak for all the other members of our pediatric cardiology group, these cases of post-vaccine myocarditis would be a minuscule price to pay if it meant that we would never see another case of MIS-C. And so we would be behind the vaccine 100%. I'll be available for questions related to myocarditis in the Q&A session, but for now, I want to pass things over to Dr. Deborah Levine from Pediatric Emergency Medicine to take us through the rest of the myths.
Thank you, Dr. Flynn. So we're going to go on with our Mythbusters. And the next myth we're going to talk about is allergic reactions to the vaccine. And this idea is that allergic reactions to the Pfizer vaccine are common. So allergic reactions to the mRNA vaccines, specifically the Pfizer vaccine, are rare. And this is because allergic reactions are so rare that they didn't even show up in the initial vaccine trials in adults. So you see on the slide 10 severe allergic reactions like anaphylaxis per 4 million doses for Moderna and 21 severe reactions in almost 2 million doses of the Pfizer. So that's about, for every 1 million people vaccinated, only about 5 will have an allergic reaction. And this is more commonly seen in people with a history of allergic reactions to a component of the vaccine called PEG, or polyethylene glycol, which is the main active ingredient in a very common stool softener called Miralax, which many kids have tried. So if your child has taken Miralax, they should be okay to get the COVID-19 vaccine. And if your child has a history of allergies, it is worth discussing with your pediatrician or an allergist before having them vaccinated. But in most cases, it will still be safe and recommended. The next myth we're going to talk about is one that, has been circulating in the media, and that is that the vaccine, the COVID-19 vaccine, will affect my child's fertility. So we're going to bust this myth because this is false. Thousands of women have become pregnant since receiving the COVID-19 vaccine. And just to give a little background, this myth was started when somebody postulated that there may be some similarity between the COVID-19 virus, the SARS-CoV-2 virus, and the placenta, meaning that if you made antibodies to the virus, they would also attack the placenta. But this is not true. And if it was true, it would be the same for the vaccine as well as the virus. And that doesn't make much sense. We've also heard concerns related to the vaccine remaining in the body, and that doesn't happen. We know that the mRNA in the vaccine degrades within 3 days, and that the fat bubbles that carry the mRNA degrades within 4 days. So the vaccine doesn't linger in our body for decades. It just gives the instructions to the body, and then it leaves. So there's evidence from the real world. Now, a year since we started vaccinations, there's been no signal about decreased fertility or any increased adverse pregnancy outcomes from the vaccine. Thousands of women have gotten pregnant and have had beautiful, healthy babies. So what is known at this point, though, it is very dangerous to have the virus, the COVID-19 virus, in a pregnant woman, and it's certainly dangerous to the baby as well. So that is why we advocate for all kids and pregnant moms to get the COVID-19 vaccine. So the next myth we're going to end with is about, we've heard that children have been relatively spared from the bad outcomes of COVID-19, thankfully. But really, they haven't been totally spared. Maybe medically they have. But the overall effects of this pandemic have certainly affected our kids. So even when the kids are not infected with COVID-19, they are affected in so many ways. We have good evidence that missing school is bad for everyone. And even though schools may offer a virtual option, from surveys of parents, we know that children doing virtual schooling have reports of increased stress. There's been reports of increased substance abuse in children. And even though virtual school may work for some, it may not work for all. And there's been a lot of losses in learning, meaning children are more behind than they were expected to be. There's been decreased physical activity leading to increased obesity and increasing numbers of children with anxiety and depression. So it has been across the board, but has been disproportionately affecting children and families of color. So our children need to be in school, and vaccines can make that possible. So at the very least, if your child gets COVID or is unvaccinated and exposed to somebody with COVID, they're going to be stuck at home, isolating or quarantining for at least 10 days. So that's 10 days of missing school, not being able to go to the playground, spend time with friends or family, and maybe lost work days for the parents. And if you have more than one child in the house, you could be stuck at home for maybe 20 days or more. So this is important, and this is why we're encouraging the vaccination in children. So before we go on to the Q&A period, we're going to address two more questions that we've been getting from a lot of parents. The first question is the variations on the same theme. So I have a small 12-year-old, should they get the smaller dose? Or I have a large 11-year-old, should they get the larger dose? Or my child will turn 12 midway through their vaccine series. The dosing was not based on weight, but rather age. And this is because of how the immune system develops and changes over time. So no matter the size of your child, you should get the appropriate vaccine based on their age. And then the last question, when will the younger children be able to be vaccinated? And we are very hopeful that it'll be soon. The Pfizer trials are still ongoing, again with a phase 1 trial to determine the proper dosing, and then phase 2 and 3 trials for the immunobridging and the safety for children 2 to 5 years, and then 6 months to 2 years. And they are trialing doses as small as 3 micrograms for the younger children. So we are hopeful that the data will be out by the end of this year.